We set out to both validate and interrogate a finding that was published last year in Lancet Oncology from the group from Dana-Farber, which showed that for the first time they found a molecular feature in the germline of renal cell carcinoma patients that was associated with worse survival and tumor recurrence. Right now we usually use tumor features and patient features in terms of predicting risk after surgery. What this does was add an additional value to that system, and what we found in our study using the Cancer Genome Atlas cohort, which had both clinical and biological information, that we did validate this finding, and we actually found that it may have other factors within MET. It was discovered by Tony Shoari and others from Dana-Farber. And what we found, we looked for this particular variant within the MET oncogene, which is a known gene that drives other types of cancers, particularly papillary renal cell carcinoma, but we focus on clear cell, the most aggressive form. And we were able to find that this variant did indeed predict worse survival, about 3- to 4-fold increase over the current prognostic factors for predicting adverse events. So we found that it does actually hold up. Next, we then looked to see what the variant does, and we found that it probably acts to activate the gene in an interesting fashion. That's the exciting part. I mean, we found that this variant probably acts in a region of enhancement for the gene, which stands to argue that it might activate the gene. And the exciting part about that is that there are many MET inhibitors, meaning drugs that are currently used in other cancer types and are being explored in renal cell carcinoma for use to combat metastatic disease. If this stands up, then we could have a marker to both predict poor prognosis but also therapeutic implications. We truly have found another molecular biomarker to predict adverse outcomes in clear cell carcinoma. It adds to the current best prognostic models that we have, so that's the first message. That's clear. The second point that we hope is that it seems to be activating the gene. And if that's the case, we can hopefully prove, at least first in the lab, then hopefully in patients, that when you have this risk variant, not only are you more at risk for metastatic disease, but you might have a biomarker for what drug you should place that patient on. Right now, all our treatments the main treatments for renal cell carcinoma are only life extending, and right now they're focused on different pathways, such as the mTOR pathway or the VEGF pathway. This is a new pathway and might be able to be used in complementary fashion to these other drugs, and might offer the patients a better shot.